sorry, well, I'm not saying to you don't be radical. You go ahead and be radical as you like, but you've got to understand that the radicality may well be of value in some patients with these diseases. Now, you can go more radical. So if you do your radical vulvectomy in somebody with lichen sclerosis, you have to remember in the past, we used to treat symptomatic lichen sclerosis with radical, not radical, but vulvectomy. It'll come back. It's not a treatment. And therefore, that's the point I'm making, is you are not going to beat off a field effect by saying, I'll take the whole lot away. The pre-malignancy is most likely going to come back, so I wouldn't do that. And therefore, the point I'm making is that the second field recurrences are something you're going to have to live with at this moment in time, but that may be going after the primary tumour in a field effect scenario, going very radical on that is probably not going to change what's going to happen elsewhere no matter what. So you're caught. You're a little bit caught on this one, and how we get out of it, I can see prevention being one of the ways out of it, but I don't think we're going to cut our way out of this, is what I'm saying.
And what about the isolated nodal recurrence in vulvar cancer?
Sorry?
Isolated nodal recurrence.
Of lymph node recurrence, this is separate. And therefore, one of the problems that you looked at of the original, when they were talking about margins, one of the difficulties in the analysis done was that these were patients who had different stage disease, so they had positive recurrence of the lymph nodes as well as locally as well. And that probably was confused matters. I think I would look at lymph nodes entirely differently. And my attitude, although this is not, is probably reasonably true, is that once you get recurrence in lymph nodes, you've got a very serious problem. This patient now, I won't say completely palliative, but they're often looking at that. And you're going to need surgery probably just to alleviate immediate potential of what we call blowout, femoral blowout, which you don't want. And then you need local and systemic therapy in many cases. So it's a much, much more serious condition.
Professor Sean, I have questions. What's the role of corticosteroids in prevention of cancer?
So this is what we're trying to do in the study, was to see if we could prevent it. And all I can tell you is that the only clinical evidence of the use of steroids and not developing vulval cancer comes from an Australian study that was based in a private practice study of over 500 patients. The patients were put on maintenance therapy, Dermavate 3 times a week. And they asked the women, and they followed up for 5 years, they asked the women, did you take it 3 times a week or not? And they were very honest. So there's lots of variables like this where some women said, we didn't. And about half of them said they didn't actually comply all the time. And other half said, actually, we stuck with it. And the ones who said they did not comply, at 5 years, their incidence of vulval cancer was 4%. And those who said they did comply, it was 0%. So we have clinical evidence. If we're looking at other areas where we can tackle, if you start interfering with cell lines of vulval cancer with steroid therapies or precancerous ones, you can start to influence that as well. There are other drugs that we could use also to influence certain pathways that go slightly askew in the development of vulval cancer. But I leave that like that just for the time being.
If we address the field change for the lichen sclerosis with the steroids,
yeah.
How or can we address the field change in the HPV with anything like topical Vicrimode creams?
Yeah, I suppose you could kind of look at that. We just went for the steroids because I said we've got evidence to support that on basic science that could be a good way. But I'm not denying that HPV may be the driver. So it might be your HPV in the milieu of the steroid, the lichen sclerosis together, is setting you up. Because if you take that cohort of patients, their relapse rate within 5 years is kind of about 60%. They're a very high relapsing rate. So it's very, very high for that specific cohort. Forget about, when you join them all together, you get about 30%, but actually that cohort is very high. I think the problem with imicamod is the side effects, unfortunately. They really, really are nasty. Whereas the steroid does have some hope, sufficiently enough that we felt the evidence that we had to support it, although not brilliant clinical evidence, that we had enough to be felt to go ahead for a phase 3 randomized type study. So there's enough there. Steroids are definitely a much easier one to give rather than imicamod.
Thank you very much.
I would have a question. Unfortunately, I didn't hear all of your presentation, but I would like to have a comment on tumors in genitalia and then on the skin. The second field effect outside the genital organs.
It's always great when somebody else being at the beginning. I would say I covered that at the very beginning, but I didn't cover that at the very beginning. But if you look at the field effect thing, the biggest story, where it all started was in head and neck cancers. And of course, as you know, head and neck cancers and HPV are very closely associated. So there's a debate about, let's say I'll get this right, is HPV positive to head and neck cancer have a better outcome than those who don't? And the relationship between HPV and tongue and head and neck cancers is a real association. So it's in the 50s that Slaughter brought in this field effect from excising a tongue cancer, if you like, radically, and then finding another one that's just turned up elsewhere. So it does fit into other types of malignancies as well. Whether you can move in is about 4 or 5 other tumor types. So breast cancer, we know now there's a field effect there. And that's where you see where people used to do very radical surgery. If you go back, so Professor Mason in Cardiff went back and looked at all the radical mastectomies because they thought there might be a field effect, and sure enough they found that if you go down and up, you'll find other malignant cells elsewhere in the breast, although the primary tumour is clear and it looks like it's all normal tumour around it. So breast cancer has a field effect as well. So about 4 or 5. Prostate is one considered with a field effect, interestingly, and there's about another 3. So the big one for us in relation to our gynecology, HPV and such like, and of course lichen, because we still get lichen sclerosis elsewhere, is probably the head and neck and the vulva.
I would like to continue or specify my question. Probably I didn't express myself quite correctly. Would you like to compare the tumors, these second field or field effect tumors in vulva or then in the loin, on the skin of loin? Is there?
So you're talking about, are the second field tumours in any way genetically different from the primary field tumour? I haven't looked at that. I don't know the answer, not for vulva. I mean, it's a very good question. Is there a difference within them? Intuitively, I'd say there probably isn't, but I'd be very careful with that because I'm always worried about intuition. It often is proven wrong, but we haven't done that. But it's a very valid point.
I have a strange question. For the picture of bladder cancer patient, very aggressive, and then said she has a colostomy.
Yeah, well, you can see why, because we're just going to cut that out. So that's the colostomy is done first, and then we go.
Colostomy first before.
We just whack the colostomy because we're taking a lot of weight there. The anus and everything is right
So
around.
it should be done first.
So colostomy is done first.
Is second field effect related to the stage of cancer development? I mean, is it more common what's the stage compared to early stage?
Advanced stage.
Yes, of vulval cancer. Is it more to have this second field effect? Without the stage?
Yeah, we kind of excluded the advanced stages altogether. And the reason we're excluding those is that if you look at your advanced stage and you start to get recurrence, the issues are, you do get it of course, but the issue of advanced stage are different. It's usually a lymph nodes situation you're talking about. So they are a different cohort. For these cohorts of patients who are node negative patients, the clinical problem that you have with them is local recurrence usually rather than nodal recurrence. So they tend to cause problems there. So on a clinical basis, we're really focusing down on those rather than the nodal positivity, which makes it a different category altogether. But you will get local recurrence there, yeah, and you will get field effects, of course. But what you find is that's not your major problem, it's somewhere else maybe.
Information could be
Thanks very much.
Thank you.